It is now my privilege, since it is 9:30, to introduce Amie Shao. Amie Shao is a director with the Mass Design Group, which does crazy cool stuff, which you're about to see. Her role there is that she oversees research focusing on health infrastructure planning, design, and evaluation. So in addition to guiding impact research for mass-built projects, she leads the development of capital project impact assessment guides aimed at providing the philanthropic sector with tools to monitor and evaluate the impact of their capital investments to build better projects. She's been working with the National Health Infrastructure Standards for the Liberian Ministry of Health. And the notable fact that I actually discovered last night as I read through her bio is that we're actually part of the same kind of little think tank, Ariadne Labs, that Atul Gawande runs in Boston. And so she's a colleague that I've not met before, but am thrilled to have her here today. So please join me in welcoming Amie Shao to the stage.
Hi, can all of you hear me or see me? I know I don't stick out so much past the podium. Is that all right? Well, thank you so much for having us here today. It's really an honor to be part of this conversation. I'm going to be talking today for a little bit about intersections between health and the built environment. So just to kind of give a brief background on who I am, my name's Amie. I'm a director of research at Mass Design Group. And we pursue a lot of healthcare-related design work, which is a lot in mainly limited resource settings like Africa and Haiti, but also increasingly in places like the US. We do a lot of kind of typical architecture stuff like design and construction-related work, but we also do a lot of research and policy work as well, which we feel is really important in kind of expanding the role of architecture and health. So one of the things that makes us a little bit unique is that we're a nonprofit. So we like to joke that a lot of architecture firms are kind of nonprofit by default, but we're a nonprofit by intent. And that allows us to partner with mission-based organizations to pursue grants and do what we think is really important work. So I'm gonna go over a few different types of projects that we're working on today to really show kind of different ideas of how we can leverage architecture and the built environment to improve lives and support healthy communities. So I'm gonna begin quickly with our kind of genesis story, which I think frames that a little bit, and then walk through a variety of projects. So Mass really began not with the intent of creating a firm, but with a need or an idea. When some of us were still in graduate school back in the mid-2000s, about 10 years ago, we went to a presentation hosted by Dr. Paul Farmer, who many of you may know is the founder of Partners in Health and a leading practitioner in the area of global health. And Paul talked a lot about healthcare delivery in limited resource settings. He talked a lot about also things that they were doing, like building schools, which we found were really intriguing because, as architecture students, it wasn't evident in the beginning why schools had anything to do with healthcare. But throughout the course of his presentation, schools and housing and all of the other things that are necessary to support community health were really the focus of all that Partners in Health was really trying to do on the ground. And afterwards, we approached him and struck up a conversation, and we're really saying, this was so inspiring. How can we as young architects help? What are the architects that you're working with, and can we work with those? And he said, architects, we don't use architects. I drew the last hospital that we built on the back of a napkin. And this was pretty stunning to us that buildings and infrastructure was a core part of their mission and a core part of achieving health, but they weren't working with or connected to the professionals that were really invested in doing so. And that we saw that as a really critical gap. So we continued this conversation, and soon thereafter, Paul invited us to collaborate with him on a district hospital that they were building in the Barrera district, specifically in the town of Butaro. So this was the last district in the country that had yet to receive a hospital after the genocide. And it was a beautiful area. There are these chains of volcanic mountains. It's a stunning, scenic area with gorgeous climate. But there were 400,000 people with not a single doctor in the whole district. And as we began to think about how we could partner to develop a district hospital in this really limited resource setting, Paul introduced to us this precedent of Tugela Ferry Hospital in South Africa, and that became a really important precedent in spurring how we were thinking about design, how design could succeed and how design could fail. So in this case, like many hospitals built in these settings, it was a kind of prototype or stamp that was kind of placed irregardless of context, of climate, of setting, of culture, kind of any which way in different places. And the problem with that is that it was inappropriate. It was inappropriate to the type of care being delivered and the type of people and needs being served. So what you have here is called in architecture parlance a double-loaded corridor, which means a hallway which has rooms on both sides and isn't ventilated in the middle. So when you have things that don't match up with the environments and with the needs and the constraints, bad things happen. And in this case, people came in for simple things, like coming in with a broken leg or a broken arm, and they came out with tuberculosis. And they developed a strain of tuberculosis called extremely drug-resistant TB, for which there wasn't really a ready cure. And dozens and dozens of people died at this hospital, and it was largely due to the design of the hospital itself. The hospital was what gave them that disease and what killed them in the end. And this was a fact that was admitted readily by the director of that facility. So, with the failure of Tugela Ferry, it sparked this really important idea in our minds. If buildings have the potential to make us sick, can they also make us healthier? And that doesn't just mean making us less sick, but making us actually healthier. So that led Mass to, this is really before its founding as an office, but in our early practice, it led us to an early thesis, which was buildings and built infrastructure can be leveraged to improve the health of individuals and of communities in the broadest sense possible. So I'm going to walk through a few different facets of what we mean by that. So I'm going to show some examples of buildings that heal, or buildings that can be designed and engineered to directly impact health outcomes of the people, the patients and the staff and the users within them. I'm going to talk about the ways in which buildings fit into and influence the kind of ecosystems and decisions and behaviors that are important for healthcare delivery. And then I'm going to talk about examples of how infrastructure is necessary for resilient health and resilient communities. So starting with the first one, going back to that original project or sparking point that I mentioned, Butaro Hospital, here's a before picture and an after picture. And Butaro was developed on this remote hilltop in the Burur district. As you can see, it has stunning views, gorgeous mountains surrounding it. And one of the main ideas that drove it was, if hallways are what's making us sick, big buildings with lots of corridors in them that are unventilated, how could we break up a hospital to create a series of buildings that are pulled apart from one another and that have hallways on the outside rather than on the inside? And we were lucky enough in this case to do it because of Butaro's wonderful climate, which is about the climate of your outdoors right now. And we created outdoor waiting spaces. We pulled everything to the outdoors, and we also integrated this idea of redundancy. So we often talk about redundancy as a bad thing, but in this case, we really engineered redundant systems so that if one failed, the others would still keep working, which is really necessary in limited resource settings where electricity goes out all the time. You may not have running water. So a lot of the ideas were about, sure, we need these low speed, high volume fans at the top to pull air and draw it up and exhaust it safely. But if those don't work, the building shape and the openings in the wall are designed in a way that it captures breezes coming over that hill and pulls them out, even if that system fails. So we stuck with open wards because we found that data showed that in this particular area, single patient rooms actually didn't work well, and people were dying faster in them because there wasn't the nursing and medical oversight to be able to adequately look after people kind of pulled apart in that way. So the question then was, how can we design wards that work really well and lead to a good patient experience and help people heal faster? So one thing we did was we inverted the traditional, is called a nightingale ward. So beds on the outside looking in towards one another with a kind of walkway down the middle. And the idea behind this was so that we could actually open up more of the outside walls to make the windows bigger, but also so that patients wouldn't have to look at other sick patients, but could look outside to these natural views. So here's a little diagram showing how that worked. That also allowed us to do this kind of half-height wall in the middle that we could run electricity and medical gases down. So it was a different way of thinking that really radically repositioned the idea of the ward and allowed us to do a lot of other things, like put the nursing station in the center as well, so that the nurses could maintain a direct line of sight to everything. So here's some different photos of the outside views and circulation spaces. Landscaping played a huge role in this and making it kind of integrated into the community and creating clear pathways and access for people to be able to get around the facility efficiently and know where they needed to go. And places for family members as well. So one of the things that we were able to do and step back and look at from this project is that the hospital as a whole has really had a lot of direct impacts on the facility, direct impacts on this area. And a lot of that was because, as you know, there wasn't a hospital here before. So the services provided have really been instrumental in reducing child mortality, giving people access to healthcare who didn't used to have it, and lowering things like maternal mortality as well. But the story about just providing a hospital in a bare bones way is very poignant to us, because bare bones hospitals kind of don't ultimately draw people and inspire the confidence in the health system that a well-built facility integrated into the community does. And I think a lot of the lessons that we've drawn from this project about starting a conversation from the ground up, integrated with the health professionals who will be running the facility, integrated with the community members who will be using the facility, we're very much about how to make a facility fit into the community and kind of grow out of the community. So I'm gonna just end this section by talking about some of the things that we're trying to do, kind of translating some of these lessons to the US, just very specifically to do with ventilation. So in this particular case, a lot of the drivers of this project was this idea that natural ventilation can actually be harnessed really well and to create safer spaces. And our question here was, why doesn't that happen in the US? We're not arguing that every single space in a hospital should be naturally ventilated. There's different considerations with kind of different acuities of spaces. But the fact that a lot of our spaces look like this, where they're kind of completely sealed, was something that was really curious to us. So we began looking into all of the different codes and standards that govern healthcare infrastructure in the US. And what we found was that a lot of these requirements of 12 air changes per hour, for instance, in certain types of spaces, which is basically 12 times the volume of air of a particular room moved out over the course of an hour, were really rooted in history and not in evidence. And so what we began to do was to look back and try to challenge some of the things that exist and really think about how we can make them be better and how we can think about healthcare codes that govern our infrastructure that are more adapted to the particular places in which we work and aren't these kind of blanket one-size-fits-all requirements that are applied without respect to kind of context. Another group of projects I'm going to talk about really have to do less with impacting directly the health outcomes of the people inside them, but impacting the way in which we as people make decisions and choose certain behaviors that are kind of health-seeking behaviors or not health-seeking behaviors. So the first project I'm going to cover really quickly is a maternity waiting village that we worked on with the Ministry of Health in Malawi. So Malawi, as you may know, has pretty bad maternal mortality and neonatal mortality rates, in large part due to the fact that it's pretty rural. And people live hours and hours from health facilities. So the problem here is that when it's time to give birth, women can't reach health facilities in time to receive the kind of formal medical services that they need in order to deliver safely. So the idea of a maternity waiting home is something that has come up in the last decade increasingly, and people are beginning to build these all across limited resource settings. And the idea is that rather than have a woman try to rush to the hospital and make it in time or not to a facility, that you go a couple weeks in advance, particularly women who are at risk of complication, and you wait near a facility until it's your time. The problem is that the prototypes being used by ministries of health and NGOs and international agencies aren't really being built with much evidence as well. So what we see in Malawi is this facility that's, again, a double-loaded corridor, a lot of women in one room, and it really ends up looking kind of like a horse barn. And when you think about yourself 2 weeks before pregnancy, making the decision of whether to show up ahead of time to wait in this place for your birth, thinking about the prospect of going to a hot, stuffy, unventilated place where you're in there with 30 other women isn't exactly a kind of enticing prospect. So the real question was, how do we design facilities that actually do what they're meant to do? They encourage women to come, they encourage women to stay there throughout the course of when they're supposed to stay there, and perhaps even inspire women to tell others about this and encourage them to come as well. So here's an example of how we really have to radically think about the actual goals of what buildings are supposed to do and challenge them and make sure that we're designing to them. So here's a view of the outside of that facility. So what architects typically do in these conditions are they look at local building systems and materials, they look at context and the climate and the site. But one thing that we find is really important to do is really place a high emphasis on stakeholder engagement, to understand who the users are, what the conditions are that they're arriving with. And I don't mean medical conditions, but how many people are they arriving with, their attendants, their other children, all of their stuff, and what's happening. So what we found was that at these existing facilities, a lot of women were just sitting around outside all day long with a ton of stuff in the hot sun. And so the idea really sparked of how to create a kind of village system that was more in keeping with the kind of local cultural expectations of kind of smaller groups, smaller social groups that could hang out and socialize and bond and share, maternal advice on the course to becoming a mother. And the idea really sparked this other idea, which was to compare a new intervention with the standard Ministry of Health facility, which would really be a great setup to show how could we show that a better designed facility, one that was beautiful, one that was attractive, to what degree would that actually be successful in attracting women, retaining women, and hence getting the health outcomes that we are really after. So we set that up from the beginning as a study. Here's a plan of the facility. It's broken up into different smaller pods of 4 women. Here's some intermediate construction photos before the landscaping was put in. I think the colors are really beautiful. There were cooking spaces and other types of spaces involved as well, not just sleeping spaces. And what we're doing right now is we're interviewing a whole range of women at each of these facilities. We're doing a quantitative evaluation that's gone through the whole IRB process, and we're going to be interviewing 300 women at the standard facility and at our facility to really go through with this evaluation. We're really excited to see the outcomes. Another kind of maternity-related project, but one in the US that we're pursuing in collaboration with Ariadne Labs and with funding from RWJF, as Jay mentioned, is a collaboration with Neil Shao and his team looking at the impact of design on clinical care in childbirth in US labor and delivery floors. So the idea here is that there was this seminal paper published a few years ago that showed that C-section rates range from 7 to 70%. And that was something that couldn't be explained by the condition of the mother or the context, basically. And we're not arguing that C-sections are a bad thing, but C-sections for women who don't need them are perhaps a bad thing. And Neil's main thesis was that the facility itself could be a risk factor. The design of the facility itself could be influencing the decisions that clinicians are making to urge women to have C-sections kind of sooner or later. So we're looking at 3 different ideas having to do with this. One is capacity. So how does the design of labor and delivery spaces impact basically the pressure having to do with the number of women in the spaces at one time? We're all looking at workload, which is how certain design elements impact the amount of pressure having to do with the workload that's imposed on a provider. And then we're looking at motivation or culture, which is about the kind of nature of the space and how that might set a certain tone or expectation for high intervention or low intervention practices. So we're looking at a range of different types of facilities, including hospitals as well as birth centers, from high volume to low volume, from high intervention to low intervention. We're looking at their floor plans. They're distributed across a range of different geographic areas. We're standardizing those floor plans in architectural software program called CAD and visiting a lot of them in person. Right now what we're doing is we're compiling all these different facility profiles and beginning to pull back and look at some of these different design factors and compare them. So the whole point of this first year of study, just to give you a little bit of explanation, is really just to identify the factors that could be influencing clinical decision making and not yet going into the evaluation portion. So that would be a next year follow-on. But I think that this group of projects is really interesting because it talks about how design doesn't just impact people directly, but it impacts the decisions or the behaviors that are needed in order to advance good health in the long term. The last one, which I'm going to kind of skip through really quickly, is about how architecture plays a role in kind of resilient health system building. So a project that we worked on shortly after the Haiti earthquake was in collaboration with JESCU, a great nonprofit located in Port-au-Prince. And they were grappling with the cholera epidemic that hit Haiti after the earthquake, where you saw a lot of people being treated in these temporary facilities. They're hot and stuffy, and cholera is an immensely kind of unbearable and embarrassing condition. So we partnered with JESCU to think about how we could build a long-term, long-lasting, permanent facility that would enable their staff to do their work better and more efficiently, that would enable patients to have a better experience, one that would allow them to kind of weather their condition in dignity with light and air flow and plants, as you can see. But what we really had to do was think deeper about the role of architecture. And what we came to the conclusion that we came to was that architecture wasn't only supposed to provide a place in which patients could get better and receive treatment for cholera, which they already had, but it could be leveraged to think about how to prevent cholera and the spread of cholera in the first place. So one of the things that was happening in these temporary tents was that the waste was being collected and just dumped back into the wastewater, groundwater system. And so what we began to think about was how could we design the facility so that it has a kind of self-enclosed wastewater treatment system so that the cholera-infected waste from these patients wasn't being released back into the groundwater. And the final product, as you can see here from the street, really is this kind of beacon and something different that really people from the surrounding informal areas come to for treatment, and one that will stand within the waves of cholera that come about in the future. So I'm going to skip through this presentation really quickly of this project, which is about let me go backwards. a one-stop shop for family and social services in Poughkeepsie, New York, which is this kind of Rust Belt, low-income area north of New York City. It's located in an extremely limited resource setting in the US context, and they provide a whole range of different types of services, and it's an incredible place, but they're really under-resourced, and what we were trying to do was help them think about how they could better leverage their existing resources to create spaces that would actually draw people there and make them comfortable and allow the services that they wanted to provide to be provided. A lot of that had to do with branding, thinking about how we could rejuvenate the look of a space and make it less scary. It also had to do with how we could leverage this one building intervention as a way to spark and catalyze larger systems thinking about the broader community and the broader environment, not only creating different kind of parks and community gardens, but also restoring the environment and making the community physically more resilient against further disasters. So a lot of that integrated different food programs, different kind of landscape intervention programs as well. And then the last thesis that I think I'm going to talk through with the video rather than presentation is that it's not just the idea that buildings can influence health and healthcare delivery in those three ways that I mentioned, but it's the process of developing those systems that actually matters. So the process itself can kind of improve lives and strengthen communities. So the Butaro example that I mentioned, we were able to hire thousands of people, which really injected a lot of money into the local economy and really made people own the facility. And people come to the facility on their days off and clean it up, and they keep it up because they feel like it's theirs. But the Color Treatment Center project, which I mentioned a minute ago, has a really great story that it's going to be narrated through one of the metal workers that worked on it. And I think that will do a really great job at explaining to you our kind of vision about how investing in buildings can influence health in the broadest sense possible.
Ça qui est spécial pour moi, c'est un domaine qui est artisanat, parce que c'est manuel. Mes amis, mon proche côté les collègues. Grâce à Dieu, on va mourir. De nous passer par artisan, tout le monde a fonctionné. Les gens qui sont venus côté, puis qui ont bagarré en nuit. Et tout a été à vivre. Mais toute zone la vivre, tout parce que si comme la même là.
We believe that people, in order to develop their full potential, they need to have health opportunities, educational opportunities, and job opportunities.
Et gestion, on travaille moins fait, un patron, moi travaille forme là, et puis moi carotter yo. Chaque dimension gagne qui à 15, 30, 45, 60, plus moi retirer timitan fait 3, ensuite moins couper. Moins décoller. Si négatif dans mi-temps là, ça fait 5. Transporter là sur site là. Je descends jusqu'à ce que je vienne by ça, chaque dimension gagne qui. Moi fait, je ne film comprendre mais les lettres à la fin, je viens voir son L.
We are looking at a place where the building itself will be comfortable for the patients and that's well ventilated. At the same time, it's linked to every other aspect of health and economics.
Je contrat comme ça encore avec elle. Bien qu'elle dit, mais au moins 4 ou 5 comme ça. Je suis passé dans la machine, je regarde. Des fois, madame me connaît la machine, je regarde. Ah, mais bah, ça belle, on fait. Je dis, ouais, j'en finis. Je vais prendre une photo, je suis très fier. Content de participer là-dedans parce que même contribuer là, on bagage qui est utile pays. En communauté, bon, il s'est passé. Faire partie des artisans qui ont fonctionné bon ici.
So just to conclude for one last minute, people often ask us why we work in places like Haiti and Africa, and it's pretty obvious that the needs are great and the barriers to innovation are slimmer in many senses, but I think we fundamentally believe that places in which we work over there aren't really that different in a lot of senses from the needs that we face at home, and there are a lot of limited resources in the same place, in the same way, here in the US. And I think that leads us to just thinking about, continually to thinking about ways in which we can apply the lessons that we've learned abroad closer to home, and continuing to make an argument for the fact that, what we really need to be thinking about is not the cost of what good design or what kind of holistic thinking about infrastructure does, but what the cost of not doing so is. So thank you very much for your time.